This is an abstract that we put together with Doug Tremblay from Mount Sinai, and really trying to understand if there is any way that we can predict for those patients that develop rapid or marked reductions in their platelet counts when they get on ruxolitinib. So we know that ruxolitinib is approved for myelofibrosis. It's really a mainstay of treatment that we have for this disease, also approved for polycythemia vera in the second line setting. But one of the things that can be quite challenging in treating patients with ruxolitinib is dealing with thrombocytopenia. It leads to dose reductions very frequently. These lower doses we know are not as clinically efficacious as higher doses in terms of improving splenomegaly. And now as we're getting other JAK inhibitors that are getting approved that may not be as myelosuppressive, it would be nice to be able to identify a group of patients that we know have a high risk of rapidly dropping platelets or dropping platelets by a marked amount, because those might be patients we follow more closely or maybe queue up for maybe treatment with a different JAK inhibitor. And so in this abstract, we try to look at a number of different clinical and genetic variables to see if we can identify different factors. I think it actually proved much more challenging than we thought. And really we found that really the key driver, the key force is really starting platelet count. That tends to be the driver that suggests that there's going to be these more substantial or more clinically important drops in platelet counts. And while not shocking by any means, I think something that can help guide us as we kind of enter this era of multiple JAK inhibitors, where we know which patients we might be able to queue up for a different JAK inhibitor or at least monitor more closely after starting ruxolitinib.